Every great event brings about transformations in the way we live, treat each other, and expand our understanding of the human spirit. The last horrible pandemic 100 years ago reminds us of the First World War. A notable story from that era is that of the first woman Nobel Prize winner, Marie Curie. She was determined to counter the effects of the gruesome war with a device to save lives. She developed the first radiological car, a vehicle containing an X-ray machine with a photographic darkroom equipment. It drove right to the battlefield where army surgeons could use X-rays to guide their surgeries. Today, driverless shuttles transport COVID-19 tests at major clinics. We're seeing transformations from a virus that will change how patients are treated for the next decade, perhaps most notably the virtual approach to medicine. In telling the story of recent transformations in healthcare and what they mean for our system in workers' compensation, we will share 4 chapters that we will read from a book of many more as we explore data-driven trends in workers' comp, both today and in the decade ahead. Chapter 1, Delivery. Non-physicians are crucial to the health of the workers' compensation system. Physical therapists have always played a critical role in workers' compensation. Now, physician assistants and nurse anesthetists are assuming an expanded role, often at a discounted reimbursement rate. Here's the interesting news. The share of all professional services performed by non-physicians in 2012 was just under 50%. Come 2018, that had increased to nearly 60% of all professional services. Physical medicine, anesthesia, and even some surgery are some of the areas that have driven this trend. According to the Bureau of Labor Statistics, physician employment has been inching up at roughly 1% per year. Non-physicians' employment has grown at a much faster pace. And that trend is expected to continue for the decade ahead. The increasing share of services provided by non-professionals, combined with potential non-physician discounts, could be contributing to a slower growth of physician costs. And that is dampening the long-term medical severity trend in workers' compensation. Telehealth is the big headline here. In a short matter of 2 weeks, we have seen physician offices turn into video conference rooms and nurses triage patient calls from home. Walls of rules and regulations have been broken down, allowing the needed care to be delivered. Will the pattern of loosened rules stay put? Will it hold? It is hard to imagine that the walls will come back up. Taking a look back at a few years, we find that the adoption of telemedicine and the use of remote patient monitoring devices can reap some significant savings in the range of 2 to 6% of workers' compensation medical costs. 3 main areas can provide significant savings here. 1, the emergency room services, with fewer injured workers having to go there. 2, a significant reduction in hospital readmission rates. And 3, finally, something that's perhaps very common today, conducting physical therapy sessions in the comfort of the injured worker's home. Well, not everything can be done at home, of course. Surgeries, when you think about it. Now, where surgeries are taking place has also been shifting, continuing a long-term trend of being conducted in the hospital outpatient settings, and quite often in ambulatory surgical centers, or ASCs for short. These are facilities that are strictly used to conduct certain types of surgeries. In 1970, the first ASC opened in Phoenix, Arizona. Today, there's close to 6,000 Medicare-certified ASCs. It is no surprise given the advancement in medicine, like faster-acting anesthetics, facilitating the use of less invasive techniques, such as arthroscopic procedures. Let's see how this expansion in ASCs has impacted workers' compensation. More than 2 out of 5 major surgeries in workers' comp were performed in an ASC in 2018, up 13% since 2012. Orthopedic surgeries like arthroscopic knee and shoulder surgeries are driving this trend. After 2016, that share seems to level out, possibly driven by increasing hospital buyout of physician practices, including that of ASCs. Taking a look at this map, we see that it shows the 2018 shares of major surgeries occurring in an ASC in 2018. The range is from 8% all the way to 65%, reflecting 1. The availability of ASCs, 2. The mix of surgeries by state, network agreements, and finally regulations that dictate what type of surgeries can be performed in an ASC. In fact, in 2020, the Centers for Medicare and Medicaid Services, the CMS, has eased the limitations on surgical procedures that can be delivered in an ASC. Now that clears the path for greater utilization of the often less expensive facilities, and workers' compensation will certainly follow suit. One may wonder what this map may look like in 10 years. We're really not sure, but industry experts estimate that outpatient surgery volume will grow by some 15% over the next decade. ASCs will most certainly aid in fielding that demand. So, more non-physician care and more ASCs lend us to believe 2 things. 1, lower prices for related experience in workers' compensation, and 2, more alternatives for injured workers. Which brings us to Chapter 2, treatments. Treatment patterns have changed in the past decade, but nowhere more notably than in response to the opioid epidemic. In fact, the share of prescription claims receiving an opioid has decreased by some 40% over the past 6 years. Drug formularies, stricter prescribing guidelines, and increased awareness of the risk of addiction are driving this trend. The use of opioids is common at the onset of an injury during the acute phase of the treatment. But the greatest concern has been the continued use in the chronic phase, 90 days or 3 months after injury, when pain and dysfunction linger. NCCI data shows that 60% of all injured workers who have some kind of medical encounter after 90 days receive services to address chronic pain. And 70% of injured workers with chronic pain are prescribed opioids. It is evident that long-term opioid use is a problem. However, there is a promising shift. MME, or morphine milligram equivalence, is a way to measure the level of intensity of opioid medications. And guess what? We have seen almost a 50% drop in the amount of opioids that injured workers suffering from chronic pain are prescribed. Prescribing patterns are changing and will continue to change, but the pain does not magically disappear. Its persistence remains an important factor in the injured worker's path to recovery and return to work. So what treatments and strategies are being used in workers' compensation to manage the pain? One such treatment is massage therapy. Studies have shown that massage can be effective in treating multiple sources of chronic pain, including hand and neck. The share of injured workers suffering from chronic pain who received massage services is relatively small, with about 1 in 105 claimants receiving such services in 2018. And while that number is small, it is not insignificant, as the rate has more than doubled since 2012. Also widespread in managing pain is the use of orthotics. Now, about 1/2 of injured workers with chronic pain have made use of an orthotic, which has increased by over 25% since 2012. Orthotics can be used post-surgery or in lieu of surgery, and they are used to provide support, correct instability, or immobilize an injured body part. All 3 of these functions can assist to provide pain relief. Physical therapy is a widely accepted treatment for joint and spine injuries within the industry. Several studies have suggested that patient participation and the number of physical therapy sessions are correlated with better patient outcomes. In 2018, injured workers with chronic pain received an average of 23 physical therapy sessions within the first year of injury, a 15% increase since 2012. Now, there is an increasing emphasis on addressing the mental aspect of chronic pain rather than simply addressing the physical symptoms. Psychological services, such as cognitive behavioral therapy, can teach chronic pain sufferers to cope with pain. Today, 1 out of 42 injured workers with chronic pain have received a mental or behavioral service in 2018, a 20% increase since 2012. Lesser known and somewhat controversial treatment of pain is platelet-rich plasma therapy, or PRP for short. PRP therapy is the process of extracting blood from the patient, running it through a centrifuge to concentrate the platelets, and then injecting that concentration back into the patient. The therapy may accelerate the healing of injured tendons, ligaments, muscles, and joints. It is now being used off-label to treat pain as well. PRP is still relatively a rare procedure, costing $900 on average, with only 1 out of every 257 injured workers suffering from chronic pain receiving the treatment in 2018. However, the prevalence of PRP within chronic claims has increased greatly over the past 6 years. Treatment patterns in chronic pain are changing and they will continue to evolve over the next decade and beyond. Transformations in pain treatment impact opioid prescribing, thus shaping medical cost trends profoundly. While sometimes conservative pain treatments may not be enough. Take a look at neck injuries. Neck injuries arise from a variety of causes, the most common of which is strains or injuries resulting from activities such as lifting, pushing, or pulling. The second most common cause of injury is motor vehicle accidents, which have increased consistently since 2012. They now represent 1 in 4 neck injuries. For the most part, neck injuries are diagnosed with the medical condition neck pain and are considered mild. Very few require major surgery. However, when injuries result in diagnosis with more severe conditions like cervical disc disorders, conservative treatment is often not enough and surgery is much more common. In 2018, injured workers from such conditions accounted for just under 25% of active neck claims, but 85% of major neck surgeries. Our exploration of transformations in neck surgery focuses on injuries with these severe ailments. The most common neck injuries performed has consistently been the anterior cervical discectomy and fusion. Fusion for short, accounting close to 60% of major surgeries in any given year. This surgery is performed to relieve pain caused by degenerative discs. It involves removing the compromised disc and fusing the adjacent vertebrae together. One alternative to cervical fusions has been gaining traction in workers' compensation: the cervical artificial disc replacement. Here, the compromised disc is replaced by an artificial one without the need to fuse the vertebrae together. The benefit being that natural range of motion can be maintained and potentially put less stress on adjacent vertebrae. The first single-level device for cervical artificial disc replacement was approved by the FDA in 2007. By 2012, several additional devices were approved, and disc replacements accounted for roughly 3% of all major workers' compensation surgeries on the neck. And by 2018, even more devices were approved, and the share of disc replacements tripled to account for 9% of all major neck surgeries. So we're seeing more of these procedures. What about their costs? In 2018, a single-level artificial disc replacement cost about $36,000, 3% more than fusions in outpatient settings. Now, the surgical visit is just one piece that contributes to the overall cost of a claim. We looked at costs over a 2-year period, 2015 through 17. We found that 2 years after injury, disc replacements averaged about 9% less in incurred medical costs and 19% less in incurred indemnity costs. That's a significant cost reduction. A caution here: disc replacement candidates are overall healthier and face stricter patient selection. But research points to several other factors that may also reduce the overall claim for those receiving disc replacements. A systematic literature review last year by Health Quality Ontario compared the effectiveness of cervical artificial disc replacements to cervical fusion for treating degenerative disc disease. This study concluded that disc replacements offered 1. Quicker recovery, 2. Higher technical success, and 3. A lower rate of reoperation. And now this is important. For a single-level replacement, a faster return to work in the range of 2 to 3 weeks. While disc replacement has had some application to other parts of the spine, like the back, the results for those have been less favorable so far. Which takes us on to Chapter 3, Medical Technology, where there has been a lot of fascinating changes. The most common causes for spinal cord injuries are slip and fall accidents and motor vehicle accidents. These injuries can cause damage to the spinal cord and in some cases leave the injured worker permanently immobile. Based on accident years 2015 through 17, 2 years after injury, the average incurred or estimated medical costs for injured workers diagnosed with quadriplegia is $3.2 million. Indemnity costs are roughly $500,000. After 2 years, around 60% of the total costs remain unpaid. That's $2 million of unpaid medical, and of this $2 million, $800,000 will ultimately be spent on home health services. These injured workers will need to rely on others for help for the rest of their lives. Innovative treatments for severe spinal cord injuries could offer hope. Here is one example that just blew me away. Here's the story. Back in 2017, a man broke his neck in 8 places in a surfing accident in California. He was given very slim chances to ever move anything below his neck again. He had limited progress during his first 6 months of rehab and physical therapy. After 6 months, he said, and I quote, "All of the progress stopped." His story was featured on Good Morning America this past November. 11 months after his injury, he became patient number 1 in a 10-patient clinical trial at the Mayo Clinic. The treatment involved taking stem cells from his own body fat, expanding the cells in a lab, then injecting them into his lumbar spine. The response was both immediate and life-changing. During his initial stem cell injection, he said, "I could feel it. I absolutely felt something in my legs." He has since regained his ability to walk. The patient was described as a super responder. Others in the clinical trial had varying results. But if this or other treatments prove viable, it's clearly a game changer for workers who suffer spinal cord injuries. We will watch developments here closely. Now, cell therapy has seen some exciting transformations in recent years. Let's turn our focus to arthroscopic knee surgery, one of the top outpatient surgeries in workers' compensation. It is often needed after a strain or a slip and fall injury. Autologous chondrocyte implantation, or ACI for short, is one of the most expensive procedures in this group. It's been approved for over 20 years. It is used to regrow damaged knee cartilage. Chondrocyte cells are taken from the patient's knee. The cells are cultured, combined in a liquid suspension, and then injected in the damaged knee under an implanted membrane covering the damaged site. 4 years ago, the FDA created the Regenerative Medicine Advanced Therapy designation to speed the review of cell therapy. In its initial month, the matrix-induced autologous chondrocyte implantation, also known as MACI, was approved. In MACI procedures, cultured cells are evenly distributed in a collagen membrane that is cut to size and then glued into the damaged site. MACI is reported under a national drug code. It costs almost $42,000 in workers' comp and is now showing in several jurisdictions in the top 25 drugs by amount paid. In just 2 years, over half of all ACI procedures were performed using MACI. These procedures cost $15,000 to $20,000 more compared to the standard ACI surgical visit cost. Novel medical technology often comes at a price. Measuring outcomes requires time and maturity. MACI surgery comes with a heavy price, and it is not clear yet whether the benefits match the cost for MACI in workers' compensation. One fascinating example of medical technology impacting workers' compensation is the use of robotics in minimally invasive procedures. These robots may include several arms beside the camera arm, adding flexibility. The arms are smaller than hands, and this allows them to have greater range of motion. Some of the benefits of robotic-assisted surgery include 1. Reaching hard-to-access areas, 2. Reducing fatigue in surgeons that could lead to surgical tremor, and 3. Minimizing cuts to other tissue. On the other hand, the technology comes with a hefty price. For example, the Da Vinci robotic surgery system costs just under $2 million in capital investments, hundreds of thousands of dollars in annual service costs, and thousands in accessory costs for each surgery. So the costs and specialization limit the use of robotics today. But how much, if any, use of robots has there been in surgeries in workers' compensation? And for what type of surgeries? NCCI data shows that about 2 out of 3 robotic surgeries in workers' comp are for inguinal hernia, and another 19% is for other hernias. Roughly 90% of inguinal hernia claims that require surgery are caused by strain, the single most common cause of injury for lost time claims. Overall, inguinal hernia surgeries make up a sizable portion of workers' comp medical costs. They represent the 13th most common outpatient surgery and the 4th largest contributor to outpatient surgery costs. Looking at recent history, we see that robotic-assisted hernia surgeries went from almost non-existent in 2012 to just over 5% in 2018. One may wonder why the volume of robotic surgeries is somewhat limited. First, we note that a hernia surgery without robot assistance typically costs $9,000 when performed in an ASC setting. Where it is mostly performed in a hospital outpatient setting, it costs just about $12,000. However, when robots come marching into that surgery room, the surgery costs go climbing up to about $18,000 on average. The difference in costs is driven by prices paid for the use of the facility, while professional costs are comparable. Reliable outcomes from using the robot-assisted procedures have yet to be observed in NCCI data. Early results do not indicate any cost savings. Further analysis and time are needed to gain full appreciation of whether any meaningful benefit to the injured worker is discernible. So today, not all surgeons are comfortable with robotic surgery. As the use of robots becomes more prevalent, the next generation of surgeons may be more familiar with robotics, and technological advancements may allow for telesurgery or other orthopedic surgery to potentially increase the use of robotics in the field. And as the technology becomes less novel, prices for robotics are expected to drop. However, if those remain relatively high without measurable benefit to the worker, then the increased use of robotic-assisted surgery could add to workers' compensation costs. We have seen how some of the transformations in the delivery, treatment, and medical technology can affect workers' compensation outcomes. Which brings us to Chapter 4, our last chapter, Payment Mechanisms. A value-based program focuses on the quality of care provided by creating a monetary incentive for the treatment of a patient based on the outcome of the treatment episode. In essence, it's a risk-sharing mechanism for the service provider and the payer. Value-based care in the last few years found a new life in measures associated with the Affordable Care Act. And as the cost of delivering healthcare has come under increased scrutiny by researchers and stakeholders alike. Some commonly identified value-based payment mechanisms include 1. Capitation, where the amount paid is determined by the number of patients. 2. Bundled payments, where a single payment covers all the services included in a defined treatment of care. And 3. Patient-centered medical homes. We see the focus on outcomes like time to return to work in many aspects of treating the injured worker. For example, outcome-based agreements for medical provider networks. Another feature that has taken flight recently is that of bundling. Now, the packaging of services or bundling has been evident in the reimbursement for hospital inpatient stays for some time. These are based on diagnosis-related groups or DRGs. The payment is based on a flat rate for an inpatient stay, no matter the length of stay. CMS has adopted hospital outpatient reimbursement packaging principles in the last 5 years for most surgeries, leading some state workers' compensation systems to adopt the package reimbursement mechanism. We will look at how the adopted method has impacted some of the top hospital outpatient surgeries in workers' comp by comparing the experience of those states that have adopted the packaging compared to those that did not. Rotator cuff repair is the #1 outpatient surgery in workers' compensation. Prior to adopting the packaging rules, there were only slight variations in the average visit costs between 2015 as compared to 2013. However, for states that adopted the alternative reimbursement using packaging, in 2016, the average amount paid per visit dropped by a surprising 10%, while states that did not adopt saw a 5% increase. And the lower costs continued to prevail from that point on. In the case of lower back disc surgery, ranked #3 hospital outpatient surgery by amount paid, the change in cost from 2013 to 2014 was almost identical for the two cohorts of states. However, we see the drift in 2015. The average paid per visit in adopter states dropped by 4.6% compared to a 4.1% growth in other states. And similar to the case with the rotator cuff, the cost differential continued to hold from that point on. Adoption of new mechanisms will impact not only worker outcomes by providing the necessary services, but also the long-term costs of delivering the medical treatments needed. Today, the healthcare system is positioning itself to meet the increasing needs of the growing and aging population. Non-physicians and ambulatory surgical centers are helping meet the demand of medical services. And the transformative use of telemedicine is all but certain. The opioid epidemic has challenged providers to consider alternative, perhaps more effective pain management treatments. Medical advancements and practices are making their way into the workers' compensation system. And with an industry-wide focus on the well-being of the injured worker and their return to work, payment mechanisms are adapting to reward successful treatment plans. In the last decade, we have seen medical cost trends that have been more contained than years before, most certainly impacted by medical transformations that we have discussed today. Some changes have taken full effect, and yet others are emerging. As we face perhaps the most significant health crisis of our lifetime, we look forward to the many chapters to come with hope and optimism that, much like Marie Curie's radiological car of 100 years ago, medical innovation will abound to bring about meaningful medical transformations to save the lives of our injured workers and assist them along their path to recovery.